I would like to welcome Dr. Mark Ibsen of Helena, Montana. Dr. Ibsen, thank you so much for making yourself available to talk about this current rock and a hard place that chronic pain patients have found themselves between. Your story is Your story is very similar to mine and how you got involved in treating pain. So first, could you give the listeners just a short biography of your training, practice, and your current status?
I'd be happy to, and thanks for inviting me to be on the show. This is something I feel very passionately about because I got involved in something that was way bigger than I thought it would. I've seen about 200,000 patients in my emergency medicine career, and in the twilight of my career, I decided to open an urgent care practice in 2010. I located this urgent care practice in a building next to a natural medicine doctor, a cranial sacral therapist, and physical therapy, and I hired a chiropractor to work with me as an x-ray tech. So we had lots of options to bring in alternative medicine to anything our patients were up. Around 2011, I started seeing patients come in who had been dropped by their doctor. Their doctor retired and the new doctor wouldn't prescribe their medicine for them, or they got fired for one reason or another from a doctor. The local pain clinic is very interested in procedures and doesn't prescribe opiates to patients. So the patients started coming in, and they'd come in on a Friday afternoon saying that my doctor didn't prescribe my medicines and I'm going to withdraw. And this was shocking to me. In my emergency medicine career, I have always aggressive in treating pain in patients because I've had pain myself. I've had a few kidney stones and some back surgery. And so I can realize that there is a way to treat pain, and that's if you're going to treat pain, treat it. So I thought that I was having the opportunity to help people who were in withdrawal, and anybody who's got chronic pain who loses access to their medication would be in acute pain, right?
Exactly.
So I took on some of these patients, and I thought it was my Hippocratic obligation. I signed an oath back in the day to sign them, and my oath is to do no harm. And it seemed to me that for 28 years as an ER doctor, this chronic pain was a can I kicked down the road to someone else, and then suddenly I became that someone else, and the can landed at my doorstep. And I could see that doctors were fleeing from treating pain. I've always been aggressive, and so I decided that, if somebody's been on 120 hydrocodone a month for 10 years, it's not fair to them to just drop them suddenly. And I promised to those patients I would help them as much as I could and bridge them until they could find someone else. The problem is there was no one else. So I thought I was doing my usual urgent care job of filling in for someone between doctors, and there was no doctor between and other side of it for the patient. They couldn't find anyone to prescribe these opiates, and I thought that was awful. I helped these patients as much as I could, and I actually got pretty good at helping people wean off their opiates. A lot of people did not like the betrayal and abandonment that they experienced in this context, and they decided that they wanted to be off opiates themselves because they never wanted to find themselves in a sort of a prison of dependence. As you know, however, you can't wean everybody off of opiates right away, and that happened with me as well. The chiropractor that I had hired was judgmental of the patients who came in, and she ended up saying some terrible things to patients, and I fired her. And then she complained to the Board of Medicine that I was overprescribing narcotics. She mentioned 9 cases of patients, and 7 of those patients were off opiates at the time I made referral.
It sounds like it was just a case of disgruntlement.
Well, yeah, she was disgruntled for sure. I offered her an opportunity to open her own chiropractic practice and operate independently, but she didn't want that. She was just really an angry person, apparently. But at any rate, I went before the board, and I thought they'd give me a trophy for my performance in getting people off of opiates, and instead they entered into a 4-year conflict with me, criticizing my opiate prescribing, and then ultimately shifting the agenda to my personality and claiming I was mentally ill, and claiming that my records were imperfect, which is kind of what they do on any doctor. They can't find anything else. They go after your medical record keeping. And, my theory on that is the patient is the terrain and the medical record is a map. And some maps are more accurate than others. And I thought it was more important to tell the patient story than to spend a whole lot more time on documentation, particularly given that I was people quite frequently. So I was able to get people off of opiates and help them But then that 20% of the patients didn't, and I was stuck with them. I found myself in this dilemma that I was critical of other doctors who dropped patients, which made it difficult for me morally and ethically to drop any patients that I wasn't able to get off opiates. Some of the patients I weaned were clearly dying before my eyes. They were unable to get out of bed, unable to work, losing weight, and I restored some of their original dose. I began to learn more and more about pain as the Board of Medicine was making my life so difficult about it. I thought, well, I'm just trying to help people here, but I got to learn about this. So I went to some conferences. I did a lot of, and I've been trained in listening to patients in a way that they can feel more empowered. And all of these patients benefited from that type of interaction. They really appreciated how much I listened to them and how much I was empathic with them. And they appreciated the time I spent with them because no one else had.
Right, yeah. So I know that in the course of your forming your urgent care practice, you even reached out to the medical board and to the government and to law enforcement for their assistance in giving you guidance. And from my understanding is you pretty much came up against a brick wall there and ended up just where they turned that then against you instead of for you. Can you clarify that a little bit or expand on it?
Yes. I thought it was best to have as transparent a conversation as possible with the stakeholders that were involved in this process of reacting to the opiate epidemic. As I looked into this so-called opiate epidemic, it became clear to me that the epidemic is truly in pain. There's 100 million people in pain in America, and there's only like 2.5 million addicts, and we are throwing the pain patients under the bus, kind of in an us versus them phenomenon. I mean, addicts are patients too. They deserve treatment as well. So what I found is that when the marijuana law in Montana happened, I went before the medical board if they had any guidance for me about how many patients I should see and shouldn't see. And there were some questions whether there should be a limit on the amount of marijuana recommendations a doctor should do. And they were pretty silent about that response. The medical board had a policy on their website until around the year 2010, I don't have that policy in front of me, but I sent it to you. It basically says no doctor in Montana should fear retribution from the medical board for treating people in legitimate pain situations, whether they were cancer or non-cancer. And that was the position of the Federation of State Medical Boards until the pendulum swung somewhere in 2010 or 2011.
Yeah.
So I went to the Board of Medicine and I showed them this policy that they had, and they denied that it's accurate and they denied that it's active, and they continued to prosecute. I went to the Montana Medical Association and I asked for their help and guidance with this, what I consider to be an extreme interference in the physician-patient relationship. But there is a bandwagon that people have jumped on, that patients who have pain and take opiates are bad, and doctors who prescribe for them are equally as bad. And it's sort of a phenomenon like a bandwagon or a pendulum swinging. I consider it to be a scapegoating phenomenon, and that pain patients are scapegoats because they're in pain, and their pain is invisible, and people think they must be weak because they have that pain. So I could see that someone needed to stand for the pain patients, and I began to do so. The Medical Association did not really respond either. I was visited by DEA agents, and those DEA agents came to me 5 different times, and they said, Dr. Ibsen, you're risking your freedom and your license to prescribe to patients like, and I said, well, patients like what? And they said, patients who might divert their pain pills. Now, there's plenty of evidence that says that you cannot tell who's going to divert their pain pills. It could be a grandma, it could be a teenager, it could be a banker. There's no way to predict that, and that evidence is very clear. So I responded to that saying, well, how do you know who's going to divert their pain medicine? And they just looked at me blankly. And then I asked them, well, what would you have me do instead? And they said, well, we're not doctors, can't tell you what to do. So apparently they can only tell you what not to do, which is prescribe opiates to patients. But that's kind of like telling a car dealer not to sell a car to someone who might get drunk and crash it in and kill someone. It's like those car dealers never go to jail when those accidents happen. There's no implication on a doctor who prescribes insulin to a diabetic, subsequently dies of too much insulin. We don't arrest those doctors. So the trajectory of human life is to die at the end, and I think that the key thing that patients are looking for is a great relationship with a physician who will help the pain and suffering of life and save life. There's only two things we do as doctors. We either save life or relieve suffering. And these people, boy, they were suffering, and they were upset. That's the other thing that's very clear about this, is that pain patients who are abandoned, particularly after going to doctors to get help with their syndrome and ending up with surgery, and then the natural consequence of having surgical procedures is sometimes to end up in chronic pain. And it seems to me that our profession owes it to these patients to support them after they've trusted us to help them, rather than say, oh, well, you spent a couple $100,000 getting several back surgeries, and now we can't help you anymore, and we're going to kick you to the curb.
Yeah, that's the standard. That's the standard rule of practice in the areas where I'm at. The pain patients, including the doctor who was the witness against me, the government witness in our area, basically do procedures, do the injections, do the steroids, do the all the different kinds of interventional things that they can charge insurance big bucks for. And as soon as the insurance decides, oh, well, you've done enough of that procedure, we're not paying you anymore, then the patient gets a letter saying, well, sorry, we can't help you anymore, you'll have to find another doctor. And that's basically just what they do, passing them on from one doctor to another, just milking the system for interventional charges that don't do anything. They don't get to the problem, they don't get to the cause, and generally don't help the patient. So that's kind of standard.
Well, Dr. Cheek, they're not designed to help the patient.
Exactly.
They're designed to help the doctor.
Exactly.
And it's kind of interesting. As you were talking, I realized this is like going to church and having the minister say, you know what, we don't want you in our church anymore. You got to go find a different God.
Yeah.
It's such a betrayal for people who've trusted their doctor, trusted their system that would help them. And what I often say to patients is, well, the medical model has let you down, but that doesn't mean you can't be helped. It just means that the conventional medical model is not helping you. And that's where I went with a lot of my patients. I got them lined up for acupuncture. I sent them to the natural medicine doc. I sent them to our physical therapist next door who do a lot of natural healing stuff like the biomat and energy healing, and I have a craniosacral therapist in my building. And the unfortunate thing about this is that, I don't know if I have permission to swear or not. I was going to say this. Pain is an effing terrorist, and it makes you suffer.
All right, I would like to welcome Dr. Mark Ibsen back of Helena, Montana. And in this 15 minutes interview, Dr. Ibsen has agreed to discuss with me what the CDC guidelines for prescribing opioids for chronic pain and how that is affecting doctors in their office and how they feel comfortable with prescribing pain medicine. What's happening to patients as we use these very harsh, in my opinion, harsh guidelines to restrict how many opioids a patient can receive and what that can do to the chronic pain patient. Could you give us a little bit of an overview as to what the CDC is for people who don't know, and what these guidelines represent?
I'd be happy to, and thanks for having me back, Dr. Cheek.
Okay.
That's a great question that you asked. What are the CDC guidelines, and what is the CDC? Well, the CDC is the Centers for Disease Control. The CDC has never really an opinion about how pain ought to be managed. The CDC was designed to help with infectious disease and epidemics. So they've expanded their role in pain management, and that's an interesting story that I'll just give you a brief interview on. The head of the Thomas Frieden has now resigned with change. He was head for several years, and he is a doctor who comes from a background of addiction management. He has a friend, Dr. Kolodny, Andrew Kolodny, and they used to work together in New York in trying to curb the heroin epidemic there. They've only management of patients on opiates from the standpoint of it. They took that point of view toward the guidelines and came out with these guidelines that when you read them, they don't seem that unreasonable. That yes, of course you should use opiates as your last choice for chronic pain, but even coming to the doctor is for your pain is an indication that Tylenol and ibuprofen and over-the-counter measures haven't worked. So, it's a bit of a false equivalency to say that, well, you should try cognitive behavioral therapy for pain. It's like, well, that's not going to help your broken collarbone or your wrist fracture or your appendicitis or any sort of acute pain. And it may help in chronic pain, and I think several good studies show that people who take those things on do make progress. The city wants there, however, to be a limit in amount of opiates patients get, and that is completely non-scientific. They pulled that out of their butt. There's no evidence that higher limits of opiates cause any harm to people. There is evidence that people who have higher dose opiates more often die. But that's like saying people who are on 4 hypertension medicines are more likely to have a heart attack, or people who take a lot of insulin are sicker than the people who take no insulin. The sicker patients need more medicine and are more likely to die. In fact, Dr. Forrest Pennant, in a lecture I saw him give about pain, Dr. Addison in the 70s determined that 2 of his patients died from adrenal failure from their chronic pain. So many chronic pain patients die of many reasons, and chronic pain makes people sick and more vulnerable to dying. They have more surgeries, etc. So the CDC decided that they wanted to limit opiates because they thought that opiates are a heroin epidemic. Well, a lot of opinions about that.
Yeah, could I throw in a question there? Being that this is a government organization, do you think that they might be simply throwing out a bar so that they can attack more doctors for crossing the bar?
Well, I think there is an issue of power and control, but when you look at power and control, you got to look at money. And so I think follow the money, you will see that the people involved in the guidelines were all benefiting from these guidelines. And doctors want more people to go to addiction treatment and therefore fund their addiction treatment centers like Phoenix House, which Dr. Kolodny is a part of. So that's part of it. The other part of it is some of the medical literature has been contaminated by falsehoods, sort of alternate facts is the way today's linguistics, but that they actually put in on several of their studies that opiates don't work long-term for pain. Well, that just means that no study has been done on opiates long-term for pain because we've used them since the Civil War. I mean, they used morphine in the Civil War for So saying that no study has been done on opiates that is longer than a year is a bit disingenuous because no study on any therapies has been done for longer than a year, and including the fact that there are studies that prove that epidural steroid injections are less than 50% effective in the cervical spine and about 50-50 in the lumbar spine, and yet those procedures are going on like crazy. There's no evidence that shows that doing particular back surgery makes a long-term difference for patients. It's an individual thing. Each patient has their own control in a scientific experiment called medical model or the scientific model. You form a hypothesis, you test the hypothesis, and then you change parameters of your experiment based on the results that you achieve. That's how you can manage pain with patients and say, are you better with what we're doing or not?
That's what the VAS scale tells us.
Right. Yeah, the epidemiological approach to pain is inaccurate because pain doesn't behave like an infection. I guess that's what I have to say about that. And addiction doesn't behave like an infection. You're not going to catch it. It's not like the stuff causes addiction. Addiction is a psychiatric factor. It's a spiritual condition. It's an allergy to a certain medication, and it's treated in a avoidance response, sometimes medically, and then sometimes in a spiritual context. So it's a complex thing, but implying that the 100 million people in pain in America are causing problems for addicts is actually the opposite true. People who are suffering from addiction, who obtain their opiate illegally and then die from it, families are upset by that, and I completely get it. So we don't prohibit alcohol, and a lot of people die from alcohol, like 450,000 people a year. And we tried to prohibit alcohol, and it failed miserably. Otherwise, it would be a great idea to try, but we tried it and failed. The same is true for prohibiting opiates. It's just it's clear that opiate prescriptions dropped precipitously in 2012, and were gradually dropping already in 2009, and yet heroin overdoses have soared. The state of Massachusetts did a study on this, and the CDC should have done this study. But what they did is they looked at everybody who died of an overdose, not injectable, but just a pill-type overdose, and they claimed that what they found in that study was 8% of the patients had a recent prescription from their doctor, which means 92% of people who died of a mixed drug overdose in Massachusetts died from illegal pills, stolen pills, or I think one thing that's really much more common than anybody admits, counterfeit pills.
Right.
So we're reacting to a problem. We're playing whack-a-mole with this problem. And it's all well and good to say, yes, you should prescribe opiates carefully, but the patients who, frankly, pain patients wouldn't sell their pills. They'd have to buy them back at 3 times the price. It doesn't make any sense prosecuting a person pain patient and the doctors prescribe for them when it's really criminals that are using opiates. There is an overlap. There are some criminals, and I've caught some of them in my practice, and some of that is recent. But they're there are ways, system involved for catching patients that are doctor shopping or pharmacy shopping. Every state in Missouri has a prescription drug register. Check that prescription drug register. Patients are getting opiates from multiple doctors. There are ways to manage this complex, very tricky minefield, and it requires someone with training and patience and a relationship of trust with their patient in order to manage this. And unfortunately, we have a hostile regulatory environment now that makes it impossible to do that for a patient.
Right. In my practice, when I was practicing, and this was back in, my practice was closed in 2011. Before that time, when I had doctor shoppers come in, and I recognized them through our patient prescription program, and I notified the drug enforcement agent of the area, nothing was ever done. They really don't care to waste their time with those people because they can't make money on them. That's why the target has become the physician, because with the physician, they can confiscate all the physician's assets.
What I can see about following the money, the other tricky deal is that the American Society for Interventional Pain Physicians wrote some parameters that the CDC guidelines were based on. And these parameters were designed to make sure that the procedural doctors get more. In other words, people have to submit the procedures in order to get their pain pills from their doctor. There's kind of a quid pro quo there. And patients who refuse these anymore are often discharged from those practices for being non-compliant.
Right.
And that's just tragic. It's a form of slavery or domination or something.
Right. And to me, that kind of activity is actually what would be considered, in my opinion, government insurance fraud, when patients are basically held at if you don't do these procedures that I can make $500 on, $800 on, I'm not going to prescribe you your $1 prescription pain medicine. To me, that's fraud, but they get away with it.
They're being held at needle point instead of gun point.
Exactly. One of the other things on the CDC guidelines, and basically I guess it's just something they use that actually has come up in the DSM-R, is this concept of, quote, opiate use disorder. And in my opinion, when I read that DSM description, basically that is something that basically what they're saying is if you take an opiate, you're suffering from the disorder. And then they lump into that description everyone, including true addicts. And to me, that is a misnomer and something that whoever came up with it, I think that there's a purpose for it, but I can't really tell. Would you have any information on that you could clarify that for me?
I just have an opinion. This came out with ICD-10 code, and it is the unfortunate thing about medicine is that if you don't have a diagnosis, you don't get paid, which is why so many people with psychiatric diagnoses are stuck with diagnoses that don't necessarily apply to them, because you can't go to a psychiatrist and with a diagnosis of normal. They have to give you that's called you bipolar or major depressive disorder or whatever fits them 5 criteria. So I could see from a standpoint of payment, it might be nice to add another category and call it opioid disorder. But that's sort of like calling people that are diabetic insulin disorder, or people who have heart disease aspirin disorder. It's counterintuitive. It makes no sense. There's no evidence based on coming up with that diagnosis, and it categorizes people and makes them feel flawed. And it allows people to further categorize and scapegoat a segment of the population that's practically defenseless. I mean, we don't. How do I say this? It's hard to discriminate against blacks because they're black. It's hard to discriminate against lesbians because you see 2 women holding hands. Discriminate against pain patients because their pain is invisible. And not only that, but they don't have the energy to fight back. Breast cancer has race for the cure. What was pain patients? Lymph for the cure? It's like it's possible for pain patients to rally defiance and energy it requires to create a movement because they're in pain. It's a perfect storm for the patients who used to be cared for by their physicians and care providers, and they no longer are because too damn rich.
Right, and another thing in our area was people don't dare let other people know publicly that they're on opiates, because then they could be targeted for theft, their homes could be invaded, they become targets of the local policeman. Once a policeman in our area at least knows that a patient is on opiates, they've stopped them for nothing, like saying they have a loose license plate, and immediately say, I need to search your vehicle, and if they find a bottle of pills, suddenly that person is charged with possession with intent to sell. So it is just a racket.
It totally is. There's one other issue that's worth talking about in the whole racket nature of this. Like, people ask why a lot. I have two reasons why. That I think it's the addiction doctors and the procedural doctors that are interested in opiates going away. The third reason is that we have a heroin epidemic, and heroin is abundant and cheap. And I think people need to start asking, why do we have a heroin epidemic when doctors don't prescribe heroin? And we're trying to eliminate a heroin epidemic by going after doctors. I mean, that's like going to a bicycle repair shop to get your brakes on your car fixed. It has nothing to do with the source of the epidemic. And heroin is abundant and cheap, I believe, because Afghanistan is growing it all, and our soldiers are guarding those fields.
But the problem is, as people are not getting their prescription drugs, they have to look elsewhere to cover their pain. Just the little bit of pain that I've had occasional pain. I treat all my pain with prolotherapy, so I don't have chronic pain. But with a few times that I've had acute pain, I've thought to myself, if I had to live with this chronically, I don't see how I could do it. And I can understand people who are left without a doctor, that they would say, I have to get treatment for this pain, and end up on the street with whatever is available, whether it's heroin or whether it's, I think that's how we end up with so much methadone deaths, is that people don't understand how methadone is long-acting and builds up in your system, and if they take it for a few days, they end up not waking up in the morning because their respiratory system has dropped. They just don't understand the risks with these medicines, and they're getting them off the street. And, of course, that's not the doctor's fault. That's the government's fault.
Well, it certainly is, and it's just in the same way that if someone who's in prison gets out of prison and they've been a heroin addict, and they go and they use for the first time in several years, they use the same dose of heroin that they used before. They think they know what they're doing because they're, part of being addicted is being in denial, and they die.
Exactly.
And that's what happens.
That happens just with oxycodone. If a person's been taking so much oxycodone and they end up not having it for a few weeks and they go back to their standard dose, that happened too.
So the Institute of Medicine did a study in 2011 on pain in America, and that study has not been shared widely.
Because for some reason the volume on Dr. Ibsen's phone seemed to go down quite a bit, I will read the IOM committee underlying principles that he asked and then read for us during his interview. Principle number 1, a moral imperative. Effective pain management is a moral imperative, a professional responsibility, and the duty of people in the healing professions. Number 2, chronic pain can be a disease in itself. Chronic pain has a distinct pathology, causing changes throughout the nervous system that often worsen over time. It has significant psychological and cognitive correlates and can constitute a serious, separate disease entity. Number 3, value of comprehensive treatment. Pain results from a combination of biological, psychological, and social factors, and often requires comprehensive approaches to prevention and management. Number 4, need for interdisciplinary approaches. Given chronic pain's diverse effects, interdisciplinary assessment and treatment may produce the best results for people with the most severe and persistent pain problems. Number 5, importance of prevention. Chronic pain can have such severe impacts on all aspects of the lives of people who have it that every effort should be made to achieve both primary prevention and secondary prevention through early intervention. Number 6, wider use of existing knowledge. While there is much more to be learned about pain and its treatment, even existing knowledge is not always used effectively, and thus substantial numbers of people suffer unnecessarily. Number 7, the conundrum of opioids. The committee recognizes the serious problem of diversion and abuse of opioid drugs, as well as questions about their usefulness long term, but believes that when opioids are used as prescribed and appropriately monitored, they can be safe and effective, especially for acute, post-operative, and procedural pain, as well as for patients near the end of life who desire more pain relief. Number 8, roles for patients and clinicians. The effectiveness of pain treatments depends greatly on strength of the clinician-patient relationship. Pain treatment is never about the clinician's intervention alone, but about the clinician and patient and family working together. And last, number 9, the value of a public health and community-based approach. Many features of the problem of pain lend themselves to public health approaches, a concern about the large number of people affected, disparities in occurrence and treatment, and the goal of prevention cited above. Public health education can help counter the myths, misunderstandings, stereotypes, and stigmatization that hinder better care. Now, so that you can read these and understand these principles that are developed by the IOM, I will put these on my website, doctorsofcourage.org, with the interview by Dr. Mark Ibsen.
And